Welcome to today's webinar, The Need for Accurate Quantitation of CMV and EBV in the Management of Transplant Patients. I am Cassie Saltman of Laboratories, and I'll be your moderator for today's event. Today's educational web seminar is presented by Laboratories and brought to you by Abbott. To learn more, visit www.abbott.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box to the left and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speakers for today's webinar. Dr. Scott Curry, Medical Director, Infection Prevention and Control, Charleston Division at MUSC, and Dr. Julie Hirschhorn, System Director of Molecular Microbiology, Geisinger Health System. For a complete biography on our speakers, please visit the Biography tab on the top of the screen. Dr. Curry, you may now begin your presentation.
Thank you very much. Just for housekeeping purposes, these are program materials sponsored by Abbott, and we are both presenting on behalf of Abbott. Content of the program is in compliance with regulatory requirements. There is a picture of me and Dr. Hirschhorn in our respective institutions, mine to the left, MUSC Health, which from the Medical University of South Carolina, which is a full-service transplant institution doing all the kinds of transplants that there exist except for face and hand. That includes a large stem cell transplant program where we do a lot of what we're about to talk about. We aim today to provide a clinical review of CMV and EBV disease landscape, particularly as it pertains to transplant patients, and that includes a review of the clinical manifestations of these disease entities and how it fits together with the diagnosis and monitoring of CMV and EBV in the laboratory. We will also go through the laboratory workflow considerations for transplant viral load markers, and in particular, Dr. Hirschhorn will talk about the performance of the Alinity M, CMV, and EBV platforms and those viral loads. We'll talk mostly about CMV, which is also known as the troll of transplantation. For good reason, it is a major threat to the health of both solid organ and bone marrow transplant patients. Pictured here is an H&E view of what CMV got its name from. You can see in the middle of that H&E stained lung section a large cell with a big owl's eye nuclear inclusion, which is the reason we call this cytomegalovirus. It has that histopathologic end organ appearance in every end organ this influences. CMV is a very interesting infection because it is, unlike Epstein-Barr virus, not a universal part of the human experience. There is an age-related increase in seroprevalence. If you can look at the CDC and NHANES data depicted here, showing that by the time you get to your fourth and fifth decade, approximately half to 3/4 of adults are infected with CMV. The risk factors, if you tease them out through the epidemiologic data, are, in addition to increasing age, being female, being born outside the United States, being in a household with low income versus moderate and high, having high household crowding, meaning more members of the household per unit, and having low household education and socioeconomic status. Those are all associated with increased seroprevalence. But you can see just from the slices by age that it is very easy to imagine that we have a lot of mismatch going on in donor and recipients for transplants, depending on who you pick at random from an adult population. As you might imagine, for children, there's a higher possibility that either the donor or recipient will be CMV seronegative. That's important because cytomegalovirus infection in both solid organ transplantation and hematopoietic stem cell transplant really can be risk stratified by who's got what. So in SOT world, primary infections are typical of those where the recipient is seronegative and there's a donor derivation of the infection. Occasionally, you'll see blood products are a cause of CMV if you're not using CMV depleted blood product sources. But without prophylaxis, if you give a donor with CMV, an organ, to a seronegative recipient, there is about 3/4 chance that there's going to be CMV disease, and it will occur within 1 year. And there's a significant consequence to that infection in terms of graft loss and infection mortality and morbidity, as we'll get to some specific examples. In contrast, if the recipients already had CMV before transplant, where there's R positive, as we abbreviate it, the risk of reactivation in that host is really dependent on their net state of immunosuppression. They do tend to have early disease post-transplant, and it tends to be less severe. So the high-risk donors are typically in SOT world, D plus sign, R minus sign. That's what we classify as the highest risk. If both the donor and recipient are seropositive for CMV, any infection that occurs can be from either the donor, the recipient, or some mix of recipient and donor virus. CMV is further complicated in transplant world because, unlike in immunocompetent individuals, where it causes really two main clinical problems. One is primary infection that manifests like mononucleosis does from Epstein-Barr virus, almost identical clinically, and it also causes fetal loss, miscarriage in reproductive age females. Often it's a silent infection in the adult, but causing devastating problems for pregnancy. But in transplant world, we kind of classify infection versus disease versus syndrome versus end organ disease. So in order of importance, CMV infection is any evidence of CMV replication, usually by lab assays, regardless of symptoms, whereas CMV disease is some evidence of this infection accompanying attributable symptoms. And we divide that into CMV syndrome, which is a very non-specific clinical syndrome, usually marked by some fever, malaise, weakness, constitutional symptoms, lab features like low white cell count, lymphocytosis, and then imaging evidence of CMV syndrome can include hepatosplenomegaly and definitely includes mildly abnormal liver function test abnormalities, particularly transaminitis. In contrast, CMV end organ disease is a biopsy-proved entity where you see evidence of replication in an end organ. It can be really difficult to distinguish this from allograft rejection, and it does have the ability to use immunostaining to assist pathologists in that diagnosis. But CMV end organ disease does not always correlate with what we can see in plasma and whole blood assays. The clinical manifestations of CMV hit almost every conceivable organ. As I mentioned, primary infection in the immunocompetent manifests as a mononucleosis-like syndrome with sore throat or a rash or some combination, with usually cervical lymphadenopathy that's self-limited without any treatment. In contrast, the syndrome of primary infection or reactivation viral syndrome from CMV in both SOT and in stem cell transplants has usually fever, often malaise, rash, leukopenia, transaminitis, but no evidence of end organ disease elsewhere. Moving on to end organs, however, retinitis is a fairly common manifestation of CMV. We mostly see that in HIV/AIDS patients, but you do occasionally see it in transplant. Myelitis and encephalitis and even meningoencephalitis is not totally unheard of in transplant medicine, but it is not nearly as common as pneumonitis, which is usually manifesting anywhere from mild pneumonia to lung nodules to full-on acute respiratory distress syndrome. And it's particularly a problem in lung transplant and heart transplant patients. And then GI end organ disease really has many manifestations in all known solid organ transplant types. Esophagitis, hepatitis, gastritis, colitis, and even pancreatitis, particularly in pancreas transplant patients, are all well-described entities and often need biopsies to prove because they don't always correlate well with what you see in serum assays. But when you look at the particular risks for CMV infection in solid organ transplantation, there are really two main features in play. One is the net state of immunosuppression and the type of organ. So you can see that in this particular survival analysis, lung transplants have a significantly higher incidence of CMV syndrome or infection overall compared to other organ types, whereas kidney and kidney pancreas tend to be the most favorable organ types. But that can be varying by center because each center has its own preferred immunosuppression regimen. tailored to its own risk for acute and chronic rejection. And that can have a significant impact on the risk of CMV infection in that first year after transplant. Within the donor and recipient seroprevalence categories, as I mentioned before, being positive as the donor but negative as the recipient is the highest risk situation. There's a significant risk of donor-derived infection, refractoriness to therapy, resistance to antivirals. Those are all most present in our high-risk groups. Whereas if you're D plus, R plus, D minus, R plus, those are both considered moderate risks for CMV infection. And lowest risk is D minus, R minus, where you can still get primary infection from outside sources. We tell our transplant patients to, wash their hands well and don't involve themselves with the care of sick children if possible. But that's actually the lowest risk clinical category in terms of donor and recipient serostatus. If you look at who ends up getting into big trouble from CMV infection, it is anybody that gets a solid organ transplant or stem cell transplant, but hearts and lungs have the highest rate of mortality from CMV. But there is no organ that is spared from the consequences of CMV. And because this has been known since the late 80s, early 90s, and once we had small molecule therapy for CMV, there has been a big move toward providing either preemption, which is treating infection as soon as you can have lab detection of infection, or just straight prophylaxis for infection in certain high-risk groups. So prophylaxis is a very, very common strategy in solid organ transplantation, whereas preemption tends to be the preferred modality in stem cell transplant. And you can see there are mixed results from center to center and from organ to organ. But in many cases, the preemptive strategy has been associated with somewhat lesser observed successful outcomes in solid organ transplantation. Whichever way you handle your CMV risk, however, there is a significant risk of graft loss, meaning losing the graft, which in the case of heart and lung transplant means losing your life. Retransplantation can avert that, but is not common. So loss of the graft and dying are the things that we most concern ourselves with when it comes to CMV infection. The situation is flipped a bit in hematopoietic stem cell transplant because it is no longer the D plus, R minus patients who are at the greatest risk of infection. It's the opposite. And that's because of the fact of we condition patients for transplant. So this is mostly confined to those who are undergoing allogeneic stem cell transplants, where we ablate the donor is moving into a recipient whose immune system is essentially being ablated and rebooted. And if you are rebooting with a recipient who has never seen CMV, that's of not great consequence. But if the recipient has had CMV before, that is a significant risk for CMV in that patient. And you can see because of that significant risk and because there are significant delays in engraftment and hematologic side effects of CMV therapy, there is a lot of preemption that occurs in stem cell transplant compared to solid organ. You can see at our center, we do twice weekly CMV plasma monitoring from the day of transplant plus 20 out to day 100, which is a period over which many of these patients are either in our infusion center getting near daily to 4 times weekly visits, or they're just straight hospitalized for that entire period. Weekly monitoring is done for those who are more moderate risk, and their threshold for initiating preemptive therapy at our center is 500 IU per ml after the harmonization standards came out with that. But the main reason why CMV is so complicated, we concern ourselves so much with this prophylaxis versus preemptive therapy, as I mentioned, different approaches favored in each of these different groups, is because therapy is so fraught with complications and costs. So of the small molecules we have available for treating CMV, we are stuck with our workhorse drugs, ganciclovir and valganciclovir. Ganciclovir does a lot of our initial work in this space because it is highly active. The barrier to resistance is fairly high, but it's also fraught with the side effects that are mostly hematologic. So when you're trying to have a stem cell transplant successfully engraft the donor material, having a drug that causes engraftment failure or delay is not ideal. And that's probably the main reason why in stem cell transplants there has been such a focus on preemption and not just giving these drugs as prophylaxis for prolonged periods. Whereas in solid organ transplant, where the bone marrow should be functional and can be stimulated to get over the side effects of these drugs, prophylaxis for some periods always been favored. If you get resistance to ganciclovir or valganciclovir, which does certainly happen, particularly in patients who are given prophylaxis, the backup drugs in times gone by were very, very unfavorable. Foscarnet and cidofovir were our go-to agents. They are terrible because they do not have any oral congeners. They are nephrotoxic. Both of them are known to precipitate end-stage renal disease. So very unpleasant drugs that, once you've resorted to them, were associated with a high rate of either graft loss in kidneys or just mortality and morbidity in all other solid organ types. There's been a bit of a shift toward easier drugs. So we now finally have maribavir and letermovir. Letermovir in particular has turned out to be an attractive candidate to give both for stem cell transplant and kidney transplant. It has now FDA labels for prophylaxis against CMV disease in both of those groups. Its barrier to resistance isn't ideal, but it's enough that it actually has succeeded now in several different randomized controlled trials head-to-head with valganciclovir, which is our other usual prophylaxis agent in solid organ transplant. Costs are an issue for all these drugs, of course, but the existence of letermovir and maribavir has been a big step forward in the transplant CMV treatment space. But as I mentioned, ganciclovir resistance is a thing. Unfortunately, it's more common in the centers that do prophylaxis, and mutations usually confer some degree of cross-resistance. In some of the UL97 cases does not have cross-resistance, but once you get UL54 polymerase mutations, you now have not only knocked out ganciclovir, but two of the backup drugs we used to have, and this was not an uncommon consequence. Ganciclovir-resistant CMV is associated with increased mortality, regardless of whether you have access to the new oral agents, and it was 50% mortality in lung transplant patients, highly unfavorable to develop this, whether or not ganciclovir is what you were last on. Considering universal prophylaxis' benefits and disadvantages in preventing CMV in solid organ transplant, the benefits are obvious. Ganciclovir and valganciclovir prevent reactivation of other herpes viruses, and you don't have to do any lab monitoring to see that it's working, so long as you don't see any of the signs clinically of CMV syndrome. The disadvantages are there is the risk that is significantly increased of CMV drug resistance, which once it happens, you in the old days did not have many options. In the era of letermovir and maribavir, you may have some options, but they are not as potent as ganciclovir. The adverse events with prolonged drug exposure, especially neutropenia, were always treatment limiting. Drug expense is very great even after prolonged marketing of these agents. They remain quite expensive. There is the problem of how to monitor for disease with CMV after you stop prophylaxis, which tends to happen even in the highest risk patients between 6 and 12 months. And that's a point at which patients are usually doing well, are not readily accessible to lab monitoring. And as I mentioned, we don't have an agreed upon duration, even for the highest risk patients. So how long do you do prophylaxis? Is it 6 months, 12 months, or something longer? An example of an SOT prophylaxis protocol from here, University of Alabama, you can see it's very much not only center dependent, but organ program dependent. So here you can see that very high risk donors for liver transplant are given 3 months of prophylaxis, whereas for heart transplant, the same thing is recommended for 1 year for high risk patients. So a lot of this is set by center tradition, not necessarily by randomized controlled trial experience, which is not as common as you think it would be in the transplant world. The other alternative in CMV prevention and solid organ transplant is preemption. So this is the idea that you don't give valganciclovir or ganciclovir, or that you give it for some defined period and stop it, but then you start monitoring for CMV replication in plasma. And once you determine that there is replication at some agreed upon threshold, you initiate therapy or initiate an intensified duration and frequency of monitoring. The benefits are you don't use nearly as much ganciclovir with all the adverse effects of ganciclovir in transplant patients. There's reduced drug costs and a much lower incidence of CMV drug resistance and late onset CMV disease after you stop the prophylaxis. The disadvantages is logistically complex. You've got a lot of lab monitoring to do in patients. You've got a pretty strict surveillance schedule that's sometimes difficult to comply with if you're an outpatient. There's the expense of the surveillance assays themselves, and there's a definite higher risk of early onset CMV disease post-transplant, such that a hybrid model is often anticipated for the very highest risk patients where you do prophylaxis and then preemption thereafter. What this also does not prevent is what I did not go into much, but there is an indirect effect of CMV infection on both graft rejection risk and fungal infections. If you do not prevent CMV early replication, those collateral benefits may be lost. But if you look at, as we now start to see some evidence of what can we do in solid organ transplant that isn't prophylaxis all the time, could it be beneficial in some way to do preemption? And the answer is definitely looks like it. There is, in this study by Nina Singh and colleagues that was published in 2020, a definite reduction in the cumulative incidence of cytomegalovirus disease in liver transplant recipients, which are a kind of an in-between kidney and lung in terms of the incidence and consequences of CMV infection. The biological basis for this is not entirely known, but it's looking like what happens in these patients with preemption is that when you allow replication to occur, that you stimulate T-cell immunity. Even though these are immunosuppressed patients who are getting tacrolimus or other anti-T-cell therapies and antimetabolite therapies for B-cell rejection risk, you allow enough viral replication frequently enough and don't allow it to get out of control, it appears to train up your immune system in such a way that eventually you will be able to control replication, whether you are seropositive or seronegative going into transplant. So the whole idea that preemption might be beneficial in terms of long-term CMV control is a very attractive idea and appears to be something we'll be seeing more clinical trials for in the future, is the hope. And of course, the existence of drugs besides ganciclovir and its derivatives is very attractive because letermovir does not have the significant hematologic side effects of valganciclovir. We now finally have an FDA label for prevention of CMV in kidney transplant patients because of this qualifying trial. As you can see, that the probability of neutropenia or leukopenia was substantially reduced in the letermovir group, so that you are able to keep many more patients on prophylaxis for longer periods without treatment-limiting side effects. I don't want to belabor the extreme level of detail depicted here, but I do want to show you that in terms of our kidney transplant CMV prophylaxis algorithm, you'll see many, many boxes in our nodes here where it really depends on what is the patient's current CMV plasma viral load. And you'll see that critical line there where we make a lot of decisions based on a somewhat arbitrarily established threshold of 1,000 international units per ml, which is a number that we could only kind of use in a large transplant system that's statewide in the era of WHO harmonization. The 20,000 threshold that is used there for intensifying therapy or to increase the monitoring surveillance is somewhat arbitrarily determined at our center based on observational data cohorts where those were the patients at highest observed risk of CMV complications and progression, not necessarily based on large multi-center trials. And it's up to each center to decide what is their personal comfort level of not overreacting to CMV replication, but also not sitting there while patients get at risk for graft loss and CMV infection consequences. Likewise, once preemptive therapy is started and you've gotten your CMV viral load to undetectable, whether you continue therapy for 3 months, 6 months, 2 weeks is very much center dependent. There are no trials that establish the details of what you're seeing here is very much center done by a bit of tinkering. And you can see that a lot of our treatment decisions, especially in high-risk CMV patients, are predicated on whether they ever develop a CMV IgG if they started out seronegative. So in summary, we have a lot of difficulty in CMV in the transplant world. It's a big threat to survival post-transplant in both solid organ and hematopoietic stem cell transplant recipients. Preemption versus prophylactic therapy or hybrid approaches remain very center specific and with not a great evidence basis to use either consistently. There's emerging data that suggests that the preemptive approach, at least in solid organ transplant patients, results in less overall disease as well as in less late onset disease and less CMV resistance. But we will hopefully see more trials along those lines that establish this for multiple types of organs besides liver. New CMV therapies are finally out there beyond ganciclovir, but antiviral resistance still lurks as a problem for all of them. And then plasma CMV viral loads essentially have been the standard of care for managing CMV infection or for doing preemption ever since the WHO standardized international unit scheme was agreed upon, but it's still logistically challenging. Getting a blood draw for a patient to do something with them on a weekly basis is a very logistically challenging item for that. I'm going to spend a little bit of time talking about Epstein-Barr virus and the immunosuppressed host, although remember, as a transplant infectious disease physician, this is not something I have to deal with very much, and that is because Epstein-Barr virus is not a common infectious complication of the immunosuppression related to organ transplant. It is essentially a malignancy provoker in terms of its potential. It's that way, I think, in large part because it's almost a universal part of the human condition to have Epstein-Barr virus latently integrated into our lymphocytes. 90 to 95% of Americans and worldwide adults are seropositive, so mismatches are extremely uncommon in adults, and even in children are fairly uncommon. Latent infection of the B lymphocyte pool is monitored and controlled by our T lymphocytes, and so with immunosuppression, those recipient or donor B cells can start to, provoked by EBV replication, start themselves dividing. And in SOT, this is mostly a host-derived condition that it results in a multi-system disease. It looks a whole lot like lymphoma, and in fact has a classification scheme that is very much like reminiscent of what we do in lymphoma, although simplified into 4 categories. In stem cell transplants, it's usually a donor-derived phenomenon. Most commonly, this is the #1 malignancy that we observe post solid organ transplant. It is fairly rare comparatively in stem cell transplant, mostly because those patients have a pre-existing malignancy that is more apt to recur than something new like PTLD related to Epstein-Barr virus. The risk factors for getting this in both groups are the degree of your T cell depletion and immunosuppression. So anti-T cell depleting agents used in either condition potentially raise risk of PTLD, which is post-transplant lymphoproliferative disorder, significantly. Being seronegative as the recipient and having an HLA mismatch are also known risk factors for having EBV cause trouble post-transplant. EBV viral load monitoring is actually not helpful in establishing the diagnosis of EBV-related disease. I know that's a bit counterintuitive, but because this is a diagnosis that is essentially tissue biopsy-driven, it can be used to exclude the presence of disease if it's negative, but EBV viral loads can be expected to be positive from reactivation of latent virus or detection of integrated virus in many contexts. And what you're usually using this assay for in the world of transplant is, once the diagnosis of PTLD has been established, to monitor the response to your interventions. And those are essentially one of 3 things: reducing the immunosuppression all the way or in part, adding an anti-B cell chemotherapy, particularly rituximab in stem cell transplants, and then radiation therapy either alone or combined with the first two. Preemptive therapy and prophylaxis is a completely unsettled clinical question, and there are no consensus in the guidelines for either SOT or stem cell transplant as to which patient should get this. And there is a very wide variation in guidelines concerning if you do EBV post-transplant surveillance, and if you do it, how often do you do it, and what threshold do you set? And why is it so? Because it's really messy. This is a quite old study, one of the very first published as quantitation of EBV in plasma started to become common, but you can see a significant overlap of the observed viral burden in plasma in patients without PTLD with long-term follow-up proving they did not have PTLD, and patients who do have PTLD. And people try to get very fancy and say, well, could we tie the risk of PTLD to the slope, the rate at which it's increasing? And the answer is sort of, but it's not very precise. You will easily see lots of patients who have a fairly high EBV viral burden who are not in any way, shape, or form symptomatic or have any imaging evidence of PTLD. And you will also see patients with a very modest EBV viral burden that you may want to consider repeating if there is imaging evidence of PTLD. So it's a bit of a messy topic, and that's why there isn't a lot of consensus on how we use it and at what threshold we really intensify the search for or treatment of PTLD. So as I mentioned, PCR is just not helpful to diagnose PTLD. It's a tissue diagnosis. Serial PCR may offer the means to monitor therapy in known cases of PTLD, but preemption does not really exist in a defined evidence-based society guideline consensus format because it simply doesn't exist in the same way that it does for CMV. Each center has its own threshold for treatment. It often varies by the pretest risk for PTLD, so what kind of conditioning regimen was used for HSCT, if there were anti-T cell agents used for a high-risk donor in the solid organ transplant world, particularly in children. The WHO International Standard of 2016 is probably going to facilitate a lot more informed trials that will help figure out this, the use of this assay, but it's not nearly as far along in development as CMV is in that clinical space. And as I mentioned, PTLD is a clinical diagnosis. The value of the highly sensitive PCR plasma assays is often to exclude the diagnosis in patients who are at significant pretest suspicion for disease. I would like to acknowledge very gratefully my former colleagues at the University of Pittsburgh, Nina Singh and Khadi Haidar, who are true experts in CMV management and who assisted me in finding a lot of these presentation materials. With that, I will turn this over to my colleague, Dr. Hirschhorn, talking about the lab end of CMV and EBV.
Thank you, Dr. Curry. Wonderful presentation. I enjoyed it. I'm going to switch gears a little bit and talk about the diagnostic assay for CMV and EBV, in particular on the Alinity M system. As mentioned, CMV and EBV establish lifelong latency, so we do worry about reactivation of that latent virus in immunocompromised patients, and that's why we're talking about our transplant recipients in this webinar. And patient monitoring by these quantitative nucleic acid testing assays play a very important role in patient management, as discussed. So the Alinity M, CMV and EBV assays have primer and probe sets. The probes for both the internal control and the targets are single-stranded DNA probes that contain a reporter and a quencher dye. The targets for the CMV assay are the UL34 and UL80.5 in the CMV genome. And for EBV, those targets are GP350 and EBNA1. You'll notice that both the CMV and EBV assays have a dual target design. And really being able to target two different areas of the genome helps to prevent the introduction of genotype bias. Also, the alinity M assays use what are called dark quenchers. And so those dark quenchers give the advantage of further reducing background fluorescence to give a cleaner signal. One interesting aspect of the Abbott system is that they use a particular software methodology to assess the dynamics of the amplification reaction. And this methodology is referred to as the max ratio. So in addition to looking for when the amplification curve, when the target is present, when it crosses that ratio threshold line, which is shown here in red, the software actually also compares the fluorescent ratio for each individual cycle. And that comparison of the fluorescent ratio is used to create what's called a ratio curve, shown in blue. This ratio curve has a very well-defined peak, which is referred to here at the top as the fractional cell number, or FCN. The ascending portion of this curve actually relates to the exponential phase of the amplification process. And the descending area of this curve is the transition from that exponential to the plateau phase of the amplification reaction. In particular, what we're interested in is the max ratio, or MR, sorry. By doing this sort of additional understanding of what's happening with your amplification reaction, you can actually provide several different quantitative measures. The first being this fractional cell number, which is the peak of the ratio curve. This correlates to the cycle number. The max ratio values are actually a relative measure of the reaction efficiency. So it turns out that the width of this ratio curve is actually pretty conserved. And so when there is an issue with the amplification process, you'll get an abnormal width to the max ratio, or sorry, the ratio curve. And so in addition to knowing what the crossing number is, or where the assay crosses the cycle threshold to become positive, you also get a general understanding of whether or not the reaction is a normal amplification for that particular assay, or if it's an abnormal amplification for that particular assay. In addition, the CMV and EBV assays both have external calibration. The external calibration is done every time you change the amp, the lysis, or the sample prep. And the calibration curves for these two calibrators are stored. And this is how you determine what the viral load is for the particular samples based on this stored calibration curve. For the CMV assay, the intended use is for aid in the management of hematopoietic stem cell transplant, as well as solid organ transplant patients who are undergoing viral therapies. The alinity MCMV assay can be used to assess the virologic response to those antiviral therapies. As with many laboratory tests, these results need to be interpreted within the context of the relevant clinical and laboratory findings. It should be noted that this test is not intended as a screening test for the presence of CMV DNA in blood or blood products. The results that you're going to get from this particular assay are going to include not detected. There's going to be a less than LLOQ, which is the lower limit of detection. of quantification, which is 1.48 log international units per ml. There's also a result that comes off that is the upper ULOQ, which is the upper limit of quantitation, and that for the CMV assay is 8 log international units per ml. There's a linear range for this assay, and if you were to get a result that's within the linear range, you're going to get a numerical value. As with all molecular based assays, there are going to be limitations. And so it's really important when you're thinking about what testing you're going to offer, that you spend time reading through the limitations of the individual assays that you're assessing. It's important to know during the evaluation and testing phase of these assays, where were the challenges? Where are the shortcomings of what the test can and cannot do? And so it's very important that you spend some time going through these and reading these as you assess different assays. So today I'd like to spend just a little bit of time talking with you about a multi-center study that was performed, that I was fortunate enough to be involved in, evaluating the performance of the Alinity M, CMV, and EBV assays using residual clinical samples, so mimicking more of a real-world analysis of how the assays performed. I'll start by talking about the precision of the Alinity M CMV assay. We used a 6-panel set from Exact Diagnostics, 20 replicates per panel member. This was done over 3 days. And basically comparing the expected concentration to the mean observed concentration, looking at that within day, between days, between sites. Multiple sites were involved. And we found that the percent coefficient of variation ranged from 0.9 to 6%, with a standard deviation of 0.15 log international units per ml or less for the different panel members, which is pretty acceptable. The linear range actually had an R value of 1, which was pretty fantastic to see. In addition to this linear range, there were also, there was a dilution that was made at the limit of detection, that 1.48 log international units per ml. And that was added to the linear range just to look at from the lowest limit of detection to moving towards the upper limit of detection with the highest value assessed at 6.6 log international units per ml. When we actually went and did a method comparison between the performance of the Alinity M assay versus the M2000 real-time CMV assay, out of the 752 plasma samples that were included in the study, 344 of those samples were in the quantifiable range for both the Alinity M and the M2000 system assays. And so what we found was the comparison demonstrated a strong correlation between the results of the two assays. And the generated bias between the two assays was 0.18 log international units per ml for the plasma samples, which is acceptable for most laboratories. And when we looked at quantifiable samples that were at 250 international units per ml or higher, 95.5% of the results were classified similarly by the two assays. We also with a smaller subset of these plasma samples, we were able to do a method comparison between the Alinity M CMV assay with the Roche Cobas CMV assay. 44 out of the 50 plasma samples that were assessed were in the quantifiable range for both assays, and the assays demonstrated a strong correlation again, 0.977, with a generated bias of 0.14 log international units per ml. We were able to also do something similar with EBV. The number of total plasma samples obtained for EBV were lower than CMV. As was kind of mentioned, EBV testing is not necessarily performed as often as CMV. So that was a limitation for this particular study. But the intended use of the Alinity M EBV assay, again, is to aid in the management of EBV viral load monitoring in transplant patients. So serial DNA measurements can be used to indicate the need for potential treatment changes and assess viral response to treatment. And as before with the CMV assay, the Alinity M EBV assay is not cleared for the use of, as a screening test of donors, blood products, human cells, tissue, cellular, tissue-based products. Again, the results that you're going to see for this particular assay are going to be not detected. The lower limit of quantification, which is 1.3 log international units per ml, the upper limit of quantitation, which is 8 log international units per ml, or you're going to get a number if your viral load is within that linear range. Here again are the limitations of the EBV assay. And again, I will mention just how important it is when you're assessing different assays to ensure that you read through all of these limitations. I found it useful in my own experience when I'm validating tests. Sometimes you find little nuggets in the limitations section that can help you progress your validation or evaluation of a product. This is the precision portion of the Alinity M EBV assay. Again, this came, the panel members came from Exact Diagnostics. It was a 5-panel set, 20 replicates per panel, 3 different days across multiple sites. And what we saw was the percent coefficient of variation ranged from 1.9 to 5.2% with a standard deviation of 0.14 log international units per ml or less per panel member. So again, the linear range looked good. And similarly to what we did for the CMV assay, we did a dilution of the exact panel members down to the limit of detection at 1.3 log international units per ml, and included that those replicates in the linear range analysis. For this comparison, what I'm showing you here is the comparison between FDA-approved assays. This is looking at the method comparison between the Alinity M EBV and the Roche Cobas EBV assay. There are a lot of laboratory-developed tests out there for EBV, and so in this particular presentation, I'm not going to talk about that. So for the Alinity M versus Roche EBV assay, we had 57 out of the 148 plasma samples tested in the quantifiable range for both assays, and the correlation coefficient was 0.964 with a mean bias, a little bit of an a higher mean bias of 0.35 log international units per ml. So in summary, acute viral load monitoring in transplants patients does play an important role in their post-transplant care, as well as the management of those patients. High throughput instruments provide accurate and precise quantitation across a broad dynamic range of viral loads. The dual target approach offers redundancy, which is really nice, particularly when variants can occur and also there can be genotype bias. And the Alinity-M, according to our multi-center study, I think it's pretty safe to say that the Alinity-M CMV and EBV assays demonstrated a strong correlation to other commercially available assays. I want to acknowledge the individuals that were involved in the multi-center study work, as well as collaborators at Abbott. And with that, we'll start the Q&A portion of our talk.
Thank you, Dr. Curry and Dr. Hirschhorn, for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask our speakers, please do so now. Just type your question into the Ask a Question box and click Submit. We'll answer as many of your questions as we have time for today. Let's get started. Our first question is, CMV is highly fragmented where fragment size ranges. How may CMV fragmentation impact viral load quantitation?
It's a great question. So yes, CMV fragmentation does occur. And so it's important when you're considering different assays or considering developing an assay that you think about an ideal amplicon size. Currently, the ideal amplicon size is around 100 base pairs. If you use a larger amplicon size, you run the risk of your assay under quantifying. The smaller amplicon sizes are not necessarily better either. And so really that ideal size is somewhere around 100 base pairs.
Great, thank you. Our second question that we have here is, how do you monitor that you are using the appropriate threshold?
That's mostly a trial and error approach, center to center, in my experience. There is more agreement in the CMV world than the EBV world, for sure, particularly since we haven't had a harmonized standard for as long with EBV. So the way to look at it is to look at rates of CMV mortality and morbidity at varying thresholds that your center has used historically and is using now, and it's a moving target. We, by a trial and error, have kind of arrived for the most part at 1,000 and 20,000 as our two thresholds to do different things to CMV patients at points in their care. But it could be next year we need to downwardly revise 20,000 to 10,000 based on every time something bad happens with a CMV patient, it's a M&M review, and that kind of thing is discussed and reevaluated in almost yearly batches to see if we're using the correct thresholds for treatment and preemption.
Fantastic. All right, our next question that we have here looks like has a couple of parts to it, so bear with me. Even with global harmonization and commutability efforts, there is still variability observed between assays and platforms. How can we improve on what has already been done? What other aspects of diagnostics can we consider? Do you foresee other technologies like digital PCR taking over in the future?
Yes, so I guess for me, when I think about that, I think about the ways that we assess assay performance on a more global or communicative scale, right? So participation in proficiency testing programs can really help to identify sources of variability, as well as provide feedback on assay performances. Also, data sharing and working together in these multi-center studies is another great way to sort of discuss assay performance, as well as being able to get at some of the limitations and the challenges around the assays that are on the market and the assays that will be developed. When talking about digital PCR, it's a very promising technology, in particular for precise nucleic acid amplification. But one thing that I often think of is sort of laboratory workflow. And so one of the benefits of using some of the assays that are currently on the market that are high throughput is just that, they're high throughput. And so in thinking about what we need in the future, you know, thinking about the methodology and the tech is great, but we also need to think about how that testing should be done. Automation obviously reduces error, and also just thinking about how accessible it is at the current time.
Fantastic. It looks like we have time for one more question. How often are multiple tests, i.e. CMV or EBV, ordered? Is this ordered as a panel or in addition to CMV and EBV? What other tests would you order on the same sample? And if risk-based, what are those considerations?
Yeah, bundling these two particular analytes is probably not something most centers are going to want to do frequently, unless they're dealing with a lot of pediatric cases where that might be the one circumstance in hematopoietic stem cell transplant where you might be doing preemptive therapy for both. But outside of that limited circumstance, it's not going to be common to need to do the two assays simultaneously at the same pace. There are certainly some indications for sick individuals where you'll want to use similar assays for other viruses like polyomyviruses, JC in particular. But it's difficult to have a one-size-fits-all in transplant world because we don't really have evidence for preemption in any viruses other than CMV and perhaps EBV. HSV is a virus that we don't do preemption for because we provide almost universal prophylaxis for that in stem cells, and protection against that is near universal in solid organ as well. So there's not, in my world as a transplant ID provider, I don't want to tempt people to constantly get duets of therapies unless they know what they're going to do with the result. And I would not know what to do with most of the EBV results in adult transplant patients.
Yeah, I would also just add that low viral loads are common, right? They can happen, and the clinical significance of those can be difficult to assess. And that's more than just trying to tease out specimen type, transplant type, immune status of the patient. What is the limit of detection of the assay or the test sensitivity? So I agree. I think it's very complicated to sort of think about a panel approach to it.
Thank you, Dr. Curry and Dr. Hirschhorn. Dr. Curry, do you have any final comments for our audience?
I think the one thing we didn't talk about much, but is under discussed with end clinicians, is log scales matter. I think I've had to have the discussion about how, 999 international units per ml and 1,050 international units per ml are, first, to me, the same result. And so you need to put clinical context in play when you have things close to whatever threshold you have set, and don't live and die by, non-log scale numbers. You think your physician colleagues know this? They do not. They still have trouble with higher order math. So do remind them, I think, that asking you to repeat an assay because it's close to the threshold, or having people do these assays daily or at some absurd frequency just because they're close to some threshold is not the right way to go for patients. They need their blood for other things. So I think those are under discussed in terms of the math of these quantitative PCR assays.
Thank you. Dr. Hirschhorn, do you have any final comments for our audience today?
I would just agree with Dr. Curry. I think looking at viral load trends is oftentimes much more valuable than focusing in on a particular viral load.
Thank you again, Dr. Curry and Dr. Hirschhorn, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care. Goodbye.